Yeah, sure.
Good evening, everyone. I am Dr. Jadeja. It's a midweek, that time of when appetite, metabolism, and motivation all get a bit grumpy. Tonight, we focus on a topic which is one of the most ancient survival system, the appetite, and two new modern molecules, semaglutide and tirzapetide. This is a molecule that sits at the intersection of psychiatry, metabolism, behavior, and modern therapeutics, and the two molecules that have shaken up both the endocrinology and psychiatry. Appetite is where biology becomes desire, a meeting point of memory, metabolism, and meaning. Tomorrow's need using yesterday's patterns and today's sensations. And between these sensations and imagination, a desire for food is born. So let's look at what the brain thinks about them, the evidence says, and what we as clinicians should expect in the coming years. Today's for today's session, our chairperson is Dr. Karthik Manohar Rao. He has completed his MBBS from Grand Medical College, Village Hospital, and his MD Psychiatry from Nair Hospital, University of Mumbai. He also secured the DPM second rank. Dr. Rao has more than 20 years of clinical experience directing Omkar Mind Care Clinic and managing acute care, rehabilitation units, community psychiatry programs, and even digital mental health startups. He is a fellow of the Indian Psychiatric Society, a life member of the American Psychiatric Association, and winner of Dr. A.R. Patel Award for research on aggression in psychiatric inpatients. His research spans geriatric depression, thyroid psychiatric interfaces, psychopathology in children of alcohol-dependent parents, and multiple clinical trials. And to maintain the brain hemisphere balance, he has a diploma in classical Indian music, tabla, and is learning the flute and has acted in street plays. It is an honor to have him chairing today's session. Dr. Kartik Rao, the session is yours.
Mute.
You're muted.
Yeah, yeah. Thank you, Dr. Jadeja. Actually, I'm trying to just kind of just be the introducer to someone who doesn't need any introduction. Everyone knows Dr. Malay, but a small story is that he's been my teacher all the time whenever we were in housemanship or registrarship or even after we passed MDs, we always go to him for any of our doubts, and he's the best person to uh, teach us something new, which is I think coming up very strongly in the horizon. I think today's topic, we in the coming years we should know it very well and be very familiar with these molecules, because so many of our patients who are coming to us through physicians, or even when we have patients having problems with obesity, whether it is due to our medications or due to their illness, or primarily due to their maybe genetic makeup, or due to other changes in their behavior, and we probably may need these medications to use in our patients, and that time this interplay between psychiatry and medicine will play a big role. And I think Malay the way is like known to everyone. If anyone wants a small introduction, which is maybe maybe for people who are joining us for the first time, I would like to say that he's got 12 years of experience as an assistant teacher, and and as a associate professor and a CPS for DPM students. And he's got the Bombay Psychiatry Silver Jubilee Prize in ANSEF's Bhubaneswar, January 1999. Dr. Anil Shah Best Paper Award in 29, and uh, ASIP's West Zone, Mumbai, October 1998. And he's been holding prestigious positions like the Honorary President of the Bombay Psychiatric Society in 2016 to 2017. And since then, he's been a member in IPS undergraduation education subcommittee from 2023 to 24, an advisor of IPS biological psychiatry subcommittee from 2020 25 to 26. And his areas of interest are well known. He is in neuroscience and genetics. Over to you, Malay. We are eagerly awaiting to hear from you.
Thank you, Karthik. Thanks so much for the kind words. And once again, thank you, BPS and IPS Vadodara State Branch for hosting this series, Brain on Wednesdays. Today we are going to, just a second. Okay, is this visible and am I audible clearly?
Yes.
Okay. So again, this is something which is, as Dr. Karthik mentioned, this may not apply to us per se in terms of therapeutics, but we need to know and we need to understand what is happening actually in terms of medicine all over the world, and also with its relationship to our patients, their illnesses, and the side effects or the complications that arise out of their uh, treatment. So we'll be talking a bit about appetite and something more about semaglutide and tirzapetide. And these last two drugs, and especially the last one, are considered as nothing short of miracles in the medical management of many things. Some of the top 4 or 5 illnesses that are mentioned in the ever-evolving WHO list of disorders with maximum mortality and morbidity. So, what is the difference between hunger and desire? The difference is homeostasis and reward, actually. Hunger is because there are certain chemical changes in the body from time to time in terms of, let's say, low blood glucose, low lipid levels. And these levels need to be restored for optimal physiological functioning. That's the homeostasis part. And what is appetite is more of stimulation and re-stimulation of an involuntary physiological response, because that gives us some good effect or pleasure, and we get used to it. We would want it more and more. So there is conditioning. So basically, the reward component. So hunger is homeostasis. Homeostasis is always a negative feedback loop. So once, let's say, the glucose levels and lipid levels are okay, we will not feel hungry. But when it comes to appetite, it is a positive feedback loop. So we would want it more and more and more. And then then there will be something which we call as tolerance to the effects. And then there is dependence and so on and so forth. So the hunger part is the homeostatic part, and the appetite part is linked to the reward mechanisms. That's the difference. And what we are going to concern today is the second part, because the pathology, the complications, and the outcomes are dependent on the second part. The first part actually takes care of itself in normal individuals. So basically, it's either, if you look at our typical conditioned responses, it's either negative reinforcement. So we do not want to feel hungry, so we eat more. Especially if there is a chance that, we are going somewhere and there's going to be some shortage or rationing. So we would eat. But again, that is more of homeostatic. And positive reinforcement can be to a pleasant flavor, or the feeling of satiety after having eaten something. So basically, that is the positive aspect of the hunger motivation. Now, this whole system of appetite is an integration between a number of things: food stimuli, the oropharyngeal stimulation by food, gastrointestinal signals, metabolic and adipose signals, numerous other stimuli in terms of circadian signals, stress responses, reproductive axis function, and learning. Now, what happens is this system is, again, since it is neurological, involves multiple areas of the brain, multiple neurotransmitter systems and other systems. So there is going to be plastic changes. So it's like it will change from time to time, and it will work more or less depending on how it is used. What is the frequency of is used? But there are multiple loci that we'll see, multiple neural networks involved. And what is understood is that the disorders of appetite arising is an incoordination between the components, especially the middle three ones. The problem of plasticity, the problem of multiple processes, and the problem of multiple regions. Now, that brings us to what is one of the major players, and people have kind of understood the central role of this molecule in appetite and a lot many things. And fortunately enough, people have developed agents which would work like this and bring about a lot of changes in disordered systems. So GLP-1 or glucagon like polypeptide 1, as it is called, the full form, is produced by the enteroendocrine cells in the small and the large intestine, and a small proportion of nucleus of tractus solitarius neuron. So basically two areas in the body where it is synthesized and found. So one is this enteroendocrine L cells. So we know that the intestine, the small intestine and the large intestine, in fact, the whole of the gastrointestinal system has got a gut epithelium. And this epithelium has got a variety of cells. Some of them are secretory cells, so they will secrete mucus. Some of them will secrete different kinds of digestive juices or enzymes. Basically, the idea is to break down the food molecules that weigh the bigger molecules into smaller molecules, assist in absorption, and so on and so forth. And some of these cells are specialized. They are called as enteroendocrine cells, meaning the endocrine cells of the enteric system or the gut. Now, endocrine cells, because they secrete something like this, this is a polypeptide, meaning it is a small protein, but not a big protein. So small proteins with a few amino acids are called as polypeptides. If it was a long one, very long one, it would be called as a protein. So L type of cells, which are in the epithelium, will secrete this or produce this. So that's one area. And the second area is the nucleus of tractus solitarius, which is in the medulla. So two areas. Now, since it is secreted in these two areas, it is going to have actions which are all over the place, meaning the actions will be in the GI system and actions will be in the central nervous system. Now, all three macronutrients. Now, macronutrients are the typical carbohydrates, fats, and proteins. These are macronutrients, and everything else is micronutrients, which would be the minerals, the trace elements, the vitamins, and so on and so forth. So all these three macronutrients lead to intestinal GLP-1 secretion. So when the food enters the small intestine, GLP secretion happens. So the food has to pass from the stomach into the small intestine. And when this gastric emptying is happening, this stimulates the production of all three, will produce the secretion of GLP-1. And once the secretion happens, the plasma levels of GLP-1 are elevated for hours after meals and return to baseline or basal levels only overnight. So the levels of GLP are maintained over a period of time, hours, and then they come down. And this was understood to function as a postprandial satiety or across or between meal satiety signal. Means if these levels are maintained, then we are going to feel less hungry, more happy, more full, and more satisfied with whatever meal we have had before. One of the problems that is always associated with eating disorders, and I'm not talking of anorexia or bulimia, but I'm talking of overweight and obesity, is frequent eating. Frequent eating of, let's say, non-nutritional stuff or junk food or processed foods, lot of sweet stuff, lot of salty stuff, lot of oily stuff. Now, the point is that this kind of foods will give us satiety. But this satiety is somehow short-lived. So it works like, I would want this kick again. So we eat and we overeat. Whatever it is, whatever food it is. It need not necessarily be junk also. It can be our regular meals which we have, right? Now, if the satiety is maintained for a long period of time, then we will not eat frequently. When we do not eat frequently, our caloric intake is reduced. And then we may not gain so much weight, or if we have gained so much weight, it would be easier for us to lose weight because we are not eating frequently. That is the idea. So GLP-1 receptors on the abdominal vagal efferents and the brain. So once this GLP is released, it is going to act on the receptors which are there in the gut and the brain and induce satiation. And this is what is the target that has been explored, experimented, and now we have got therapeutic agents for this. So something like this. Now these are the various players. So we have ghrelin, we have cholecystokinin, we have GLP-1, we have got polypeptide Y, of which GLP-1 has been robustly studied, and we have got molecules targeting this. So what happens? This is the stomach, this is the small intestine, large intestine, and colon. So once the food enters from stomach into the small intestine, the secretion happens of GLP-1 and it keeps on increasing till probably the food reaches the colon. So this transit time or gastric emptying time or intestinal peristaltic time is more. So food moves. It gets all the nutrients get a chance to be absorbed properly, right? And so people, since the time of emptying is delayed, people will not feel hungry. That's a physical aspect. And as we mentioned, it also induces satiety. So this is that loop. Again, gastric emptying, emptying. So all the nutrients come into the small intestine. It stimulates GLP-1. It inhibits gastric emptying. So gastric emptying is slowed down. So what are the effects of GLP-1? Now, this is the one that we have seen in the last 2 or 3 slides is mainly the gastric emptying. But where are the other effects? So one is, of course, the GI tract. Second effect is on the liver. So it reduces gluconeogenesis and steatosis. Important because if this happens, more of stored glucose in the liver gets a chance to be used. So there is reduced glucose synthesis and more of glucose utilization, and also steatosis. So even the fatty stores in the liver get a chance to be utilized. So they do not accumulate. They do not cause inflammation and the MFLD, so metabolic associated fatty liver disease or metabolic associated hepatic steatosis. So that part is reduced. Even pancreas, there is an stimulation of insulin secretion. Brain, because it not we'll see that one part is that the satiety induction. So reduced food intake, reduced water intake, and there are these effects on the memory and reward systems also. We'll see that in a bit. Effects on the heart, increased contractility, increased cardiac output, increased bone formation, increased insulin sensitivity and glucose uptake by the muscle. So people who have got diabetes, where the blood glucose is high, the sugar is not getting utilized, there is reduced insulin sensitivity or increasing insulin resistance. This helps because the effect when we exercise, the muscles are the best engines to utilize glucose. And so when we want to lose weight, there has to be a combination of things. It cannot be only dieting or it cannot be only exercise. We need to have an efficient engine, the muscles, which can utilize. But how will it utilize? It has to increase glucose uptake and increase insulin sensitivity. So the net entry of glucose into the muscles is key. And the muscles should also be good enough. They should have enough mitochondria where it will be utilized for energy production. So this is where GLP-1 helps. It helps kidneys in diuresis and natriuresis. So actually, they have got a renal protective function. So these are the multiple effects of GLP-1. Though the GLP-1 is limited, the secretion is limited to the small and the large intestine and to some part of the brain, but the effects are widespread. Now, what are we concerned about? As I said, that we are more concerned about the appetite, not the hunger. Now, this is the center of the hypothalamus. So this is the median hypothalamus. This is the lateral part. Now, this arcuate nucleus is where we have the hunger centers, or the centers which will determine I am hungry and I need to eat, and I'm not hungry, I don't need to eat. Right? So we looked at these molecules. We are not getting into that. But this is the arcade nucleus, and this actually is the homeostasis, or the main area of the hypothalamus, which looks at the homeostasis of food. But as we move laterally, so this is the center, arcuate nucleus is bang in the center. And as we move laterally, the lateral hypothalamus, so this is kind of a sectional view, but if you look at the lateral view, the central hypothalamus will be here somewhere, and the lateral part, the side parts get connected to amygdala, nucleus accumbens, ventral tegmental area, right? And so this is the driver of the reward pathway. So what happens is this gets connected, hunger gets connected to the reward pathway, and thereby we have food, we eat food not only because we are hungry, but because we like to eat certain foods. Even if we have had two nice meals and if we are going out with friends, we are going to eat something. So this is how it functions. So we are not just functioning at this level, but the food is more associated with these reward pathways in human beings. Now, when it comes to managing the appetite, it has always been a challenge because it is extremely easy to say that you eat this and you don't eat this and you do, eat only at these points in time in a day and reduce calories. It doesn't actually work that way very well. For people to follow this kind of advice, it takes a lot of motivation, day-to-day adjustments, and that is where most people will fail. Dietary regimens will go on for a period of time, and more or less they're bound to fail or flop or be partially adhered to. And then whatever weight loss has been there may not remain so. So usually the tighter the dietary schedule or the food habits that are prescribed by somebody, the more likely they are going to fail. And the weight loss will come back. So to manage this, and especially after we have understood the role of GLP-1 in the action of GLP-1 on the gut as well as the brain, and people started looking to develop agents. So starting from 2005 to 2018 and beyond. So 1, 2, 3, 4, 5 we do not have. We had semaglutide, which came around just after, at least in India, just after the lockdown. So maybe around, semaglutide is there since 4 or 5 years. And then after that, we have tirzapetide, which is there since the last about year or two. So this is the kind of a timeline. It's not a very big timeline. It's only from here, from 2005. But now, since we know this, then designing of molecules, getting them to be, getting them into trials, and then producing them and marketing them is an easier job. So what are these molecules? So we are talking about semaglutide and tirzapetide. So these are called as GLP-1 agonists, means they're going to act like GLP-1 on the GLP-1 receptors. So they mimic the action of the natural incretin hormone glucagon-like polypeptide or glucagon-like peptide 1. So we said it's released by the pancreas in response to the nutrient state, has an effect on pancreas, GIT, central nervous system, and so many others. Now, tirzapetide has got an additional property. It is an agonist also for glucose-dependent insulinotropic polypeptide. It's another similar GLP-1 like action, and because it has got a double action, it is called as a twin creatine. It's a kind of a pet name for tirzapetide. This is an incretin group of polypeptides, so it acts on this one and this one. That's why it's called as twin creatine. So what do they do? Since they are kind of mimicking the actions of GLP-1, so we have slow gastric emptying. So it prolongs the feeling of fullness after eating and reduces the frequency of hunger pangs. So some net total is decreased caloric intake. And utilization of stored fat as an energy source and reduce pro-inflammatory visceral fat more significantly than subcutaneous fat. Now, one thing which we have to remember, I think most of us would be knowing, because in our clinical practice, we interact with a lot of our physician colleagues. We have our own, some of us are on the overweight side, some of us would have T2DM or diabetes, or we might be taking some medications for whatever conditions we have. One of the things is that when we put on weight, now as we become older, when we are small children and we are chubby, the kind of fat that we have in our body is a different fat. We have something called as brown fat, more of brown fat. Now this brown fat is kind of uh, it has got a high metabolic rate, means it gets metabolized faster. But over time, and as we put on weight, and especially when we cross, let's say 35, 40, so-called middle ages, so over time, the constitution of fat is more of white fat. Now, this white fat is more of storage fat, and it is very slow to be metabolized, so it doesn't burn very easily. So what happens is that the ready fuel that is there for all the metabolic processes and all processes becomes carbohydrates or sugars. So white fat works more as storage. Carbohydrates are the ready fuel. And when we eat less carbohydrates, or the carbohydrate intake is less, or the amount of carbohydrate is less, then slowly the white fat gets channelized into metabolism. That is what happens. Otherwise, it's very difficult to get rid of white fat. So dietary restriction means that white fat may be that much, but even carbohydrates are less, so it gives a chance for that fat to be utilized in metabolism. Now, GLP-1 agonists do that. They will start utilizing, because gluconeogenesis is less in the liver, so glucose stores are not formed, and whatever fat stores are there, they will be utilized, so there is reduction in the fat. Now, why is this important? The more fat is stored in this fat cells and it remains there, it actually produces pro-inflammatory substances by itself, by not doing anything, by just sitting there. And this white fat is typically found in periviscera, means in the abdomen, but around the organs. The subcute fat which is there is not a problem. That gives us the protection and the insulation in ABCD, XYZ. That is not the important part. The important part and the problematic part is the visceral fats. The more amount of visceral fat is predisposing people to developing more amount of baseline inflammation. And baseline inflammation is now known to be associated with a number of physical ailments. Most of the non-communicable diseases that start, let's say after 40, 45, have got this inflammation as a base. So this visceral fat actually acts as a focus which needs to be addressed, right? Now, another thing that is important is that even in people who are not overweight, even if they look okay, it is actually the amount of visceral fat in their system which can be problematic. So we will know of many people in our circles, in our friend groups, or just like that, and we read about them that, okay, he looked fit and fine, but then he had a myocardial and he collapsed and ABCD. The problem is fit and fine, yes. What is the visceral fat condition like? How much of the viscera are covered, kind of floating in the fat, and that needs to be addressed, and that is the problematic fat. So at a CNS level, GLP-1 receptor activation is associated with appetite and satiety. So satiety happens at two levels, that because of this and because of this. GLP-1 receptor agonists also affect the mesolimbic pathway, specifically the nucleus accumbens and ventral tegmental area. They also modulate GABA in the central amygdala and infralimbic cortex. Means when there is GABA release, it is going to have an inhibitory effect on overacting or overactive reward pathways. We want these reward pathways to be quietened. Otherwise, it will keep on producing the craving and all those associated and consequent effects. So craving, then that cyclical, it will go on, and tolerance and all those kind of things. And also modulate dopamine signaling. So GABA is more, so inhibition of the reward pathways, and modulate dopamine signaling means it is not going to let it go beyond overwork, and it is not going to allow it to go under also. It's going to maintain dopamine. So the central neurotransmitter pathways get sort of stabilized with GLP-1 agonist. So what have people found? This is a GLP-1 pathway. And if we look at the different substances, different regions, so we have the nucleus accumbens, we have the basolateral amygdala, paraventricular nucleus, arcuate nucleus, lateral hypothalamus, ventral tegmental area here, nucleus of this is not here, so it will be here somewhere. Lateral dorsal tegmentum. And if you see the down arrow, all these areas are inhibited physiologically because of the agonism of GLP-1 receptors. So what starts off as a GI specific polypeptide has got effects which are pretty widespread, and this has actually opened up new vistas of understanding not only how we can control appetite, but how we can actually control the revolve pathways in general, and produce or kind of think about producing a clinical effect for a multitude of disorders. So talking something about semaglutide. So semaglutide is available as two formulations. One is a subcutaneous injection and an oral molecule. It's a tablet. So after subcutaneous, the bioavailability is very high, 89%. Peak concentration achieved within 1 to 3 days of initiation. So semaglutide injection subcut is once a week. Bioavailability is less. The problem is that semaglutide and tirzapetide, they are polypeptides because they are mimicking the GLP-1 per se. So like any polypeptide, like any protein that we take, it goes into the gut and starts getting broken down to the point that there will be individual amino acids, and some of them may not be absorbed or absorbed in very low numbers because they are less lipophilic. So the bioavailability range is pretty much less. And this gets affected by gastric fluid, food and water volumes, especially oral. So subcut is better slightly. And the PO, that is the oral formulation, the maximal dose is typically reached within 1 hour post dose. But this will have to be taken daily. Subcut, high bioavailability, can last longer. Oral doesn't last long and needs to be taken daily. Steady state exposure, typically 4 to 5 weeks of daily administration. So it comes close to our psychiatric medications. So following subcut administration, the mean volume of distribution is 12.5 and 8 liters following oral. Metabolism undergoing proteolytic breakdown of the polypeptide chain, followed by beta oxidation of the fatty acid side chain. Elimination half-life is 1 week. This is for subcut and both oral, and remain in circulation for about 5 weeks after the last dose. Primarily eliminated in the urine, 3% as unchanged drug. Most of it is broken down into components and in feces. Tirzapetide is called as Mounjaro, and unlike semaglutide, it is available only as subcut. There is no oral formulation available. Again, a similar bioavailability. Peak serum levels in about 8 to 72 hours. Mean steady level is 10.3, highly bound to plasma albumin. Again, metabolism is similar, proteolytic cleavage, C20 fatty diacid, beta oxidation, metabolism into individual amino acids in the liver, half-life of 5 days, so weekly dosing, and cleared in urine and feces. So apart from the additional mechanism of tirzapetide, which is GIP, in addition to GLP-1 agonism, more or less the metabolism, the absorption, the kind of dosing is similar in both. And of course, semaglutide has got two formulations, the subcut injectable as well as the oral. Tirzapetide has only one. So now what was done? Ozempic. So semaglutide is actually the same molecule which is available as three different brand names from the same company. Okay, and why are the names different? Because they got an approval for that molecule for that indication. So the molecule doesn't change, the mechanism of action doesn't change, the pharmacokinetics that we see doesn't change, only the name changes. So we have got Ozempic, which is subcutaneous for type 2 diabetes mellitus. This is one formulation. And this is first 4 weeks, 0.25 milligram once a week, injectable. So 4 injections in a month. Second month, 0.5, increment in the dose. The idea is to reach up to 2 milligrams every week in about 4 months' time. We can go up to 2.5 milligrams each week as maintenance. So the maintenance will be somewhere here, depending on what, since we are looking at T2DM, it is going to be HbA1c and other parameters, of course, in terms of all the blood biochemistry and weight and all those kinds of things. But the company marketed Ozempic was Novo Nordisk, the one which makes the Novopen and all the world-class diabetes medicines. So Ozempic is for subcute T2DM. When people started using it for obesity and overweight conditions, they gave it a name called as Wegovy. Again, this Wegovy thing is not much different, except the dosing here is slightly different. 0.25 mg to start with, 1.7 milligram each week by 4 months. So if you look here, it was 2 mg per week. Here it is 1.7. And instead of 2.5, we have got 2.4. Slight tweaking of doses here. But otherwise, it's the same kind of a thing. So we have Ozempic, subcute for T2DM, Wegovy, same molecule, subcute for obesity. And then we have Ribelsus, which is oral tablets. Actually, this was good because at least it's a tablet, it can be taken daily. This was probably available easily here. Injectables were not so easily available, or people were not using it too much, as far as I know. This was Ribelsus. So here the dose is 3 milligrams daily. First month, 7 month for another 1 month, and 14 is the target dose. So either 7 or 14. Monthly increase. So these are the three strengths, 3, 7, and 14. And depending on what is the patient preference and side effects kind of thing, there is a switching between Ozempic and Ribelsus. So it's a very simple guide. We'll not get into it. The presentation will be there. People can look at it if they're using, or figure out if the same thing is happening in their patients. So for Semaglutide, we have 3. Ozempic subcute for T2DM, Wegovy subcute for obesity, and Ribelsus overall for whatever you want to use. They have not specified that. Tirzapetide, as I mentioned, Monjaro is only for subcutaneous route. And same amount, 0.5 ml, those injections are there. The concentrations are different from 2.5, 5, 7.5, 10, 12.5, 15, almost like our olanzapine kind of dosing is there. Starting from 2.5, but instead of 20, we have got 15 here, and we have got 12.5 in middle instead of 15. Similar patterns of dosing once a week. 2.5 is the starting dose. 2.5 is something like the first dose, and it is something like the test dose which we give for many injections, whether the patient is tolerating it or not. Okay. So the initial dose, 2.5 mg subcute once a week for a month. After 4 weeks, increase to 5. The target is 15. And depending on all the parameters that we are looking at. So the primary would be glycemic control, that is HbA1c, the BMI, and then the others. So if a dose is missed because it is like once a week, so we are very well used to giving our depot preparation. So one depot, whatever, every 2 weeks or 4 weeks. So this should not be a problem if we are using. We may not use it. It's not compulsory. But point is that there are so many of the patients in the last few years who actually come to us and who are on these medications. And that is where we need to understand how they're going to, or what kind of changes they're going to tell us about, and what we should be looking for. What are the common side effects? Again, molecules are similar. Side effects are also probably similar. The commonest ones are, of course, decreased appetite. nausea, diarrhea in up to 10% of patients, vomiting and acid reflux and constipation. Because of this 10%, actually 10% side effects. So if we are giving a molecule to 100 people and 10 people have side effects, it's actually significant, whatever it is, for any molecule, any kind of side effect, any kind of formulation, anything which reaches up to 10% is, even though it can be a very non-problematic kind of a side effect, but anything that happens in 10% is significant. And because of this, there might be discontinuations. Discontinuation probably doesn't happen because of anything else, but this decreased appetite is what we want. Sinus tachycardia, infrequent cases of acute kidney injury. Why does that happen? Because this is too much, nausea and diarrhea. So they can be dehydrated. Hypersensitivity reactions at injection site, cholelithiasis and cholecystitis due to rapid weight loss, and pancreatitis. Now, for many people, when either of this molecule has been started, the weight loss is actually dramatic and fast. And because of the sudden loss, even the fats, the visceral fat which is there, even the brain chemistry that is set, when there are fast changes, they also take time to kind of, okay, what's happening? Let us get adjusted. We are quite happy with whatever is happening and now all these things. So there are going to be sudden problems. So the commonest things that happen with rapid weight loss is cholelithiasis and cholecystitis, and often and sometimes pancreatitis. Now it's probably very less, but it has been noted mainly with semaglutide and not with tirzapetide. Another thing is that people, when it comes to the complications, the microvascular complications of T2DM, one being the retinal vasculature. So if the T2DM improves, then there can be changes in the visual status, because the retinopathy also doesn't know now what to do. Should I get better? Should I, wait for a while? Whether that whatever was happening is going to remain that. So if there is a change in visual status, people need to get their vision checked. And of course, hypoglycemia. Specific dose adjustments. So we talked about the dosing pattern of uh, subcute and oral semaglutide, subcute tirzapetide. Anything specific we need to keep in mind? No dose changes in case of hepatic impairment. Actually, no dose needed for renal problems, but if there is an acute situation, then we need to be caution in those who are having excessive vomiting, nausea, or who get dehydrated easily. Pregnancy and lactation, as usual with any molecule, there is no data. Not established as safe for pediatric patients. Not really problematic for elderly people, because once T2DM is diagnosed, it is going to be somewhere in the 4th or 5th decade of life, and then it's going to be continuous. So for elderly people, not a problem. But what is important is this, that in the first 4 weeks after starting tirzapatide or semaglutide, I have not mentioned semaglutide, there would be a reduction in the efficacy of oral contraceptives. So if somebody is planning their family and tirzapatide is started, it's better that they are told that you should use additional contraceptives which are not oral contraception. So physical methods of contraception for the first 4 to 6 weeks. That was about the molecules. And what kind of evidence do we have? In fact, for these two molecules, the evidence is huge. And the evidence is, kind of the studies are done by the pharma companies themselves. So the common scenario is a molecule is getting introduced in the market. There'll be 2 or 3 good studies and they've got an FDA approval, and then we are happy with that evidence. Now, since these are very crucial, since these two molecules are very important because they address very crucial issues, there are n number of studies right from day one. Right from day one, there are so many studies that it forms a very impressive database to start with. So for semaglutide, SC formulation. So what are the SC formulation? So first one, Ozempic for T2DM and Wegovy for weight loss. So step trials, the first one. This group of trials, this is basically, I'm talking about semaglutide. P means published, NP means non-published, and active means the study is going on. So for weight loss subcute formulation, we go with so many trials have been published. List of 10, there are 7 published. And what are these? Weight loss in people with diabetes, higher semaglutide dose in type 2 diabetes, whether it leads to weight loss in along with behavior therapy. Full semaglutide benefit means how much, at least 10% of body weight loss. Sustained treatment, what happens? Metabolic syndrome in Asians, with or without type 2 DM in this non-white population. Comparative with liraglutide. Liraglutide had come before the semaglutide. Obesity and problems like osteoarthritis, obesity and pre-diabetic state. So HbA1c just touching around 6. So that was one, step trials for weight loss. Then there were step trial for teens. So in teenagers, weight loss in adolescents published. Then in heart failure with no preserved ejection fraction. So overweight or obese people with this complication. Then select trial, diabetes without diabetes but cardiovascular disease. Obesity without T2DM, obesity without diabetes. Then there are sustained trials. So this first group of trials were for obesity, overweight. This is for T2DM. Okay, so there are again so many of these sustained trials. So amount of glycemic control, already taken metformin and others with comparator sitagliptin. Okay, so comparison with other molecules that are already going on. Basal insulin with without metformin, high cardiovascular risk. So many of these are basically sustained trials. So we have got these step trials, so many, 10 plus 5. Then sustained trials, 5 up to 11. And then there are sustained variations. So again, a lot of them. So it's China specific, Japanese population. So they are trying to tell us that it's not only a certain group of people or a certain population that is getting the benefits of semaglutide. We are still talking about semaglutide, but different populations. The Southeast Asian kind of population also will benefit. Then there are pioneer trials with oral formulation. So again, that whole group and so many. So that was that whole set. This is just one line about each. But if you see, there are about 1, 2, 3, 4, 5, 6, 7, 8 slides just to list the names of trials done by Novo Nordisk, the manufacturer of semaglutide. And this is the evidence base that we have, which is pretty impressive actually. Now, when we look at tirzapetide, it's there since the last couple of years in the market. We have this SURMOUNT trial. So SURMOUNT trials are basically for body weight. So we have SURMOUNT 1, SURMOUNT 2, 3, 4. 4. SURPASS trials are both body weight and HbA1c. So T2DM with body weight. So we have got SURPASS 6, and then we have SURPASS variants also. So now this is a ready base. So this is done by the companies, series of trials, series of publications in all. This will not be there in our psychiatry journals. This will be there in JAMA or something like that, a New England Journal of Medicine, the premium medicine journals or premium endocrinology journals. Now, that was about database about weight gain, obesity, and type 2 diabetes mellitus. Now, where will it concern us? Are we going to use this molecule? If we can, we can, because it is not a very difficult proposition to use the molecules if we are okay with it. If you are not okay with it, that's fine. We'll need to refer them to our physician friends who can, give them costly molecules, and the patients will readily take it. If we give anything costly, then the problem is, it's going to go on, and then we cannot afford it. But anyway, we should be open to the fact that a lot of patients of ours who are on long-term medication, whatever it is, whether it's atypical antipsychotics or whatever molecule for whatever illness, uh, whatever be the reason, there are many patients who put on a lot of weight. And they, whatever we tell them, they will not be able to follow our instructions. There can be a residual cognitive impairment or ABCD XYZ, but the weight doesn't reduce. And the literature says that patients who have got a serious mental illness have got a reduced lifespan by up to 2 decades compared to people who do not have. So as it is, they are predisposed to something. And what are they predisposed to? They're predisposed to all kinds of non-communicable diseases right from day one. That's why anything that happens in terms of side effects, cardiac side effects or metabolic side effects or weight is going to be problematic. So we have used metformin. Everybody doesn't tolerate metformin. Everybody doesn't lose weight with metformin. So what else we can do apart from giving advice, eat less, eat this, don't eat that, don't smoke, don't take alcohol, be active. Apart from all the good words that we tell them, can we do something? So there was a study, semaglutide for the treatment of antipsychotic associated weight gain. This was a case series. Everything starts with case series, and if people pick it up and then they do a proper study, then we can be more certain, because we may be able to reduce the uh, you know uh, confounding variables and so on. Semaglutide for antipsychotic weight gain, associated weight gain, and not responding to metformin. So series of patients, 2 years, case series. It's not a randomized control trial. 2 years. So they did all the kinds of measurements: baseline, 3, 6, and 12 months, height, weight, waist circumference. Okay. They did all the measurements, and again the same kind of semaglutide dosing. Start with 0.2 weekly, dose titrated every 4 weeks to maximum 1 to 2, and tolerability of side effects. So weight change. So basically they had 11 patients in their study. So this is the kind of weight change pattern they had over time. So change in weight at 12 months. Okay, so this will be not a very good graph. It's just a visual depiction. But point is that of the 11 patients, there was weight reduction only, and over time, except these two situations where some weight had increased. So this is what happens when we are stuck with metformin. We may consider semaglutide as an additional molecule, because there are, if we see the semaglutide studies, semaglutide has been given in patients where with metformin or with any anti-diabetic medication, the T2DM has not changed. The T2DM status has not changed. So it can be combined. We can remove metformin, we can give semaglutide. That is the point. A better randomized clinical trial, the history trial, this is published in JAMA Psychiatry 2025, just 2 months back. This was a placebo-controlled trial of 154 patients with schizophrenia, overweight, obesity, prediabetes, 30 milligrams of semaglutide, 1 milligram mix. What was the finding? 1 milligram per week significantly reduced HbA1c. Semaglutide also reduced body weight by a mean of 9.21 kg and improved quality of life without worsening anything. Another thing that came up with semaglutide was, if we give this, there is a chance that depressive symptoms can increase. So this was a case study, 2 patients only, where history of mood disorders, patient had started either with, some people are able to procure something and take it on their own. So this patient started having semaglutide for weight loss, started having depressive symptoms. They took a good history and they found out that let's stop semaglutide and see, and then the depressive symptoms resolved. Similar thing with the second case. So this was case report. But there was a review, this was about 4 years back, of possible role of GLP-1 in mood, because uh, when we look at depressive symptoms, we are going to look at how the limbic system functions, how the reward functioning happens. Okay. So we would expect that in depression, I mean, we have certain data in depression that there is reduction in neuronal plasticity, reduced neurogenesis, neurotransmitter imbalance, impaired brain energy metabolism, increased neuroinflammation, dysregulation of the HPA1 axis, and gut-brain microbiome. These are the broad uh, 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 hypotheses that point to the etiopathogenesis of depressive symptoms. So, does GLP-1 AR agonism help in any way? Could help in any way theoretically. So, one, it is neuroprotective. It reduces baseline neuroinflammation. It can modulate HPA axis and stress response and regulate this because it has a change in the bioenergetic profile generally in the body. So that it was, this thing continues. So people keep on looking at it, whether Tirzapetide, since it's a new kid on the block, whether there is a risk of suicide in a real world cohort. Now, studies which are done in institutes or rather the randomized controlled ones will have strict intake criteria, strict exclusion criteria. They will also look at the significance that we get when we do comparative analysis and so on. So what did this study find? This is a real world cohort. So Tirzapetide was associated with the lower observed risk of suicidal ideation or suicide attempts compared with other anti-obesity medications. Now, the point is that here we need to think clinically is in patients who have got a chronic non-communicable disease. Two, people who have got T2DM, people who have got obesity or overweight, whether this would be associated with the primary psychiatric illness right from day one. The more we read about the basic etiopathogenesis of various psychiatric illnesses and see how they correlate with other non-communicable diseases, we will come across findings that there are common etiologies like inflammation, chronic background inflammation. So it would also mean that patients who have got depression, for example, would be more prone to weight gain, more prone to T2DM, and any of these combinations. So anybody who has got obesity can have an increased vulnerability to the other two, and so on. So when we are looking at patients who are overweight, who have got T2DM, and who have got depression, we have to actually ask for the other two. If they are not obviously overweight, then we need to look at the parameters. So in a situation like this, if you are adding something, what is it going to do? Does it improve something? Does it worsen something? And that is why this kind of a study was done. And they found that the reduction, in fact, the risk of suicide is much less in a real world cohort. And this is the number at risk. So there are quite a few number of patients. And then since some or the other side effects are reported, especially after the molecule is available, then there has to be a registry or a pharmacovigilance analysis. So this was the database, UDRA vigilance database. For psychiatric adverse events associated with semaglutide, liraglutide we don't have, and tirzapatide. So what did they found? All individual case safety reports were analyzed for about 2.5 years, 21 to 23. Descriptive statistics, 31,400 plus adverse events were reported. Semaglutide had quite a few, 13,000, almost 14,000. Liraglutide, some more, but tirzapatide had just come. So this is about 23. There'll be more data and only less than 1,000. Now, of these adverse events, how many adverse events? 31,400 plus. 372 had psychiatric adverse events. So this is about 1.2%. 370 reports with total of 481 adverse events. Women accounted for 65%. So if we kind of come down the line, almost 31.5 thousand and 372 reports or 481 reports, which is around 1.2%. So depression was the most common in N is to 187, followed by anxiety and suicidal ideation 73. 9 deaths, 8 with liraglutide, 1 with semaglutide, and 11 life-threatening outcomes were reported. fatal outcomes primarily in men from completed suicidal attempts and depression. But psychiatric events comprised only 1.2 of all this. Means if we come down the line, the numbers keep on becoming less and less and less. Now, once this is there, we have to be cautious. But we cannot be overcautious and not give a molecule which is needed. Because this kind of adverse event databases or pharmacovigilance will just keep on listing. So if I have vomiting or if I don't sleep, will also get reported as an adverse event because it is just reported. It may be associated, will not be causative. But the point is that when people have taken so much effort, 2 years, 35,000 patients, we have got some numbers which are actually in single digits. The ones that concern us, depression, suicide, are a few hundreds, and the real life-threatening ones are in single digits. So this gives us a pointer that these things can happen, this can be associated, so we need to keep a lookout for that. Now, apart from T2DM, apart from weight, apart from probable depression and something, we come to the other thing, which is alcohol and addictions. So this was one of the earliest studies. Semaglutide reduces alcohol intake and relapse like drinking in animal models. So they decided to do a study of both, because both were available, to reduce alcohol consumption in individuals with obesity. So this was something which is quite a unique kind of a study. We will not get into details, but it's a very interesting because this few slides that I have made, it was done by the researchers after there were a lot of reports coming on social media that people were using this for whatever obesity and T2DM, and they found that they were drinking less. And they were happy with drinking less. They did not feel the craving. So the initial study was analysis of social media texts. So it's around 69,000 posts on social media. So they put it into machine learning, what we would call as AI in today's world. And then you come up with themes. Okay, that was the first study. And the second study was actually people studying those people, not the social media posts. So it was participants, a small group, controlled, and the participants had significant lower self-reported alcohol intake, reduced number of drinks per drinking episode, binge drinking odds were less, and the audit scores were more favorable for reduced alcohol consumption. Okay, so this is how this study was done. So first one was social assessment of social media posts, and second a remote study. Now, since these molecules are kind of, they stabilize a lot of things, there was this thing whether, and of course obesity gets associated with a lot of cancers. So whether this has got any protective effect. This was a small research study. So in people who had colorectal cancer risk in drug-naive patients with T2DM, with and without overweight or obesity, and you give them GLP-1 receptor antagonist, what happens? So the point was that GLP-1 receptor agonists were associated with reduced risk in drug-naive patients with T2D with or without obesity or overweight, with more profound effects in patients who had them, because this is their primary effect, suggesting a potential protective effect against colorectal cancers, which may be mediated by obesity. There will be people who are not obese and will still have the risk, but then this can add a level of protection for people who are overweight. So as we become heavier and heavier, not only do we have cardiovascular risk or our joints suffer, but it also exposes our risk to metabolic liver disease and cancers. Whether this has got any, semaglutide has got any neuroprotective effect, less reduced neuroinflammation, more kind of stabilization of neurons, neurogenesis, whether it will help in whether it will help in Alzheimer's disease. So this was something started in 22. It was a joint project. It was done by the Oxford University as well as the manufacturers of semaglutide, Novo Nordisk. So it was to explore possible mechanism underlying the potential modifying effects of semaglutide. This was 22, but what happens 3 years down the line? So it was a phase 2 study. Okay. This is just 2 days back. The data is not here, but this item appeared on 24th, this day before yesterday in the Guardian. It appeared in the Guardian because it's a British newspaper, and so they're going to cover what happens as Oxford. Novo Nordisk shares slide after Ozempic pill fails in Alzheimer's trials. So the primary objective of using this, whether it is going to reduce the amyloid production, okay, was not fulfilled. So now the Novo Nordisk has stopped that trial. Now that may be bad news for us, but it's definitely bad news for the shareholders because they are going to have less dividend coming in. What happens now? Both the molecules, both semaglutide and tirzapatide, are not indicated in pregnancy because we do not have data. But that doesn't stop women from developing T2DM before pregnancy, during pregnancy, or after pregnancy. So what? Now suppose somebody has got T2DM before pregnancy. So now we have a retrospective cohort study of 1,50,000 almost single pregnancies. So not twins or anything, single. Between June 2016 and March 25, so almost 10 years, in a single academic health section. This comes from JAMA. GLP-1 use. So at that time, semaglutide was in the market, not tirzapatide. So GLP-1 use with subsequent pre-pregnancy or early pregnancy discontinuation. So women were taking for T2DM or weight, and then they got pregnant. So either the pregnancy was accidental or planned. So in either case, either the molecule was stopped before they became pregnant, or once they realized they were pregnant, they were advised to stop. And then what happened? This discontinuation was associated with more gestational weight gain and a higher risk of preterm delivery, because then all the risks associated with overweight during pregnancy came into play. So whether it was preterm delivery risk, gestational diabetes risk, or hypertensive disorders of pregnancy. So people tried to stop one, that okay, they may be associated with some problems because we do not want to give the molecule, and now they've actually landed up with documented problems which can cause all kinds of things because of overweight in pregnancy. Women will gain weight in pregnancy, but women can gain a lot of unwanted weight during pregnancy, the unhealthy weight, right? And this was from about 1.5 lakh pregnancies. So if it is discontinued, the weight loss is kind of, crossed. There will be more weight gain and more complications. Same thing. Cardiometabolic parameter change by weight regain on tirzapatide withdrawal. This is a SURMOUNT-4 trial. So one of those SURMOUNT trials which we saw related to tirzapatide, then what happened? 308 participants, they were given 36 weeks tirzapatide treatment. So this will be about 8 or 9 months. And then tirzapatide was removed. So people say that, no, I've lost a lot of weight and I'll be managing with my diet and exercise and it's good and bad and all that thing. And we stop. And what happens after 1 year? Higher degree of weight gain with greater reversal of initial improvements in weight circumference, blood pressure, non-HDL, glycemic parameters, and insulin resistance. So point is, now we have got something which is a miracle, but the miraculous effects have to be maintained over time, and this needs to be continued. This is the bottom line. Which is better? Somebody decided, now we have two. What to give? And the obvious answer is the new one. Tirzapatide, again around 41,000 patients in total. Okay. And the conclusion was tirzapatide was significantly associated, more likely to achieve weight loss. Not only that, but at all points in time, 3 months, 6 months, and 12 months. And rate of side effects, including GI side effects, as we saw, were almost similar. So in sum, what happens when we are looking at, this is the mechanism of action of tirzapatide, but it is also semaglutide because all the things are same. So a lot of changes happen which are actually good. That is what we saw. The areas that are affected are these pathways, reward pathways, which keep things going on. And once that improves, there is an improvement in everything, obesity and related physical side effects. Third, When it comes to obesity, the medicines are associated with weight and food craving reduction, improved life expectancy, reduced odds of myocardial infarct, stroke, and cardiovascular death, reduced odds of heart failure, their renal protective, liver protective, and impact on sleep apnea. So there is a new set of studies coming which are looking at sleep apnea. One of the, again, contributory factors in sleep apnea is obesity. They're associated with brain health in terms of reduction in neuroinflammation and improvement in brain insulin sensitivity. So brain insulin sensitivity, when it improves, it also has an impact on cognitive impairment, rather cognitive improvement. So better insulin sensitivity, better cognitive health. Enhanced neurogenesis and neuronal survival can reduce oxidative stress and may be associated with the reduction in developing AD and PD for semaglutide. This is out at the moment, with and also improvement in mood and reduction in depressive symptoms. Arthritis improvement is not only secondary to weight loss, but arthritic changes are inflammatory in nature. So a baseline reduction in neuroinflammation or inflammation, better outcome for arthritis. And so on with libido issues and infertility, especially in PCOS. So there can be changes in alcohol use disorders. We saw that some basic studies, not only alcohol, but in other addictions, which are not only substance, but also behavioral. So there are some small studies, but this is what we are looking at. So we started with appetite. We started at T2DM and insulin resistance. We looked at depression. We looked at addictions, and that is where we are heading. Now that brings us to the point of what are the issues. I mean, no miracle comes just like that. So when people took it for a long period of time, 68 weeks will be around 1 year, 3 months, 1 year, 4 months, 10% of muscle mass is lost. So if there is not enough dietary protein intake or resistance training, people may look really wasted. Again, GI side effects are there. Risk of thyroid C cell tumor. So this is one kind of red flag which we need to look at. We need to ask history of any thyroid cell tumors, medullary thyroid cell tumors, or multiple endocrine neoplasia 2-3 times, just to be sure. This tend to be expensive, at least in our setting, where most of the people are not getting covered by insurance. But what is also important is there a risk for misuse? So can semaglutide or tirzapetide be misused? We see a lot of people on screen who 3 months before looked somewhat different from what they're looking now. Now, whether they are actors, whether they are very successful people, whether they're athletes. So the body image issues, because I'm going to lose a lot of weight very fast, and I have got a wedding to attend next month, I will look totally different, transformed. And then I'll say it was my yoga that did it, or I was going to the spa regularly, and so on and so forth. But yeah, well, this seems to be what is happening in the background. Whether not only image enhancing, but whether they are performance enhancing. There are athletes who are good, top of their performance, and now they suddenly look different. They are active athletes, not that they are, they've stopped their, sports and they put on weight. No. So reduction, even slight reduction in body weight, is going to kind of improve the performance metrics. So this is what has happened. In fact, with semaglutide, it had happened so much that actually people who needed it as a medication for obesity and for T2DM suddenly face shortage, not available. And there are lots and lots of people who would keep on posting on social media, who you would see on regular news or YouTube videos, that they are suddenly changed. They look completely different, right? So this is something that we also need to keep in mind, because again, once people understand how that molecule works and what it does for them, many of these people who have tried this would have tried because there's an underlying body image disturbance. So thank you so much for your patient listening, and I hand over the mic to the chairpersons. Thank you so much.
Thank you, Malay, for such a beautiful presentation. And I think we've got a lot of insight into these new molecules which we'll be using, or at least we'll be seeing other physicians maybe using in our patients. And if sometimes patients come and ask us whether our medications are working or not. Like one of my patients, actually, she is on one of these molecules, but her depression is not responding so well to our antidepressants. So we were wondering whether the
Yes.
semaglutide is, creating some problems here. I think one of the questions in the chat is that is there any test to find out the visceral fat?
Yeah, sonography.
Okay,
A good sonographer can tell you what is the body comp, because they'll have everything has a different ultrasound shadow, no? So we'll come
right,
to
right,
know. So
right,
that is what I'm saying, that it is not only the body, how it appears. In fact,
right,
what people are saying now is that the BMI is not a very good marker to decide whether somebody is, I mean, of course, an overweight will look overweight, but somebody who is muscular built will also have a very high BMI. So the best
right,
way to is, take a sonography, see how the shadows are, what they are doing inside. We'll come to know.
right,
So good sonographer is needed. And of course, all
right,
the parameters, because then baseline inflammation is going to be high. So high CS, high sensitivity, CRP, T2DM, because people will be fine. They will not have a typical high blood sugar fasting or postprandial, but their HbA1c will be having a upward trajectory up to 6,
oh,
and they will be fine.
right,
No symptoms, no nothing. They will not take medication, but that some change is needed, because that is slowly shifting towards maybe not T2DM, but definitely some kind of insulin resistance.
right. Maybe we'll have to do some tests to find out some insulin resistance or steroid levels.
I had asked my physician whether I should do a insulin level. He said that insulin levels are very variable throughout the day. So you will never be able to get a proper kind of baseline. Like sugars are okay. Even if I don't do an HbA1c, my fasting is this much, my postprandial is this much, and that remains. Insulin levels are not that way. So they're not reliable when we are doing something like this.
Oh, right. Maybe Malay can take a lecture on that also.
Insulin is one topic where, again, it is cross-cutting. So insulin has got a lot to do with our with cognition, and
Right,
an integral part of how brain bioenergetics suffers, and then we have all those dementia-like changes. So that's a different thing. But yes, so I have a female patient. Interesting story. I have two. One is a middle-aged lady. She must be in her late 40s or early 50s, and she has been coming to me with depressive symptoms and body ache and all these headaches and all. She does well. She is actually good, but she's overweight and has diabetes. So 3 years back, her physician started her on semaglutide. Means since semaglutide was available, and now I think of late, since about a year or so, tirzapetide, maybe less than a year. I see her the same. Means body structure wise, there is zero change. If there is a 1 centimeter change here, there in waist circumference, I don't know. And I ask her, how is your diabetes? She says, it's the same. Have you lost any weight? I have not lost any weight. So there will be people who will have no effect.
oh,
So when there are these miracles, they do not work equally well for all of us. So that also needs to be kept in mind. Another patient is a young female. She must be in her early 30s. She has got recurrent depression. She has got a cluster B kind of a personality. So lots of ups and downs. And she has got overweight. She's overweight. And she also has now started developing arthritis. She says that I have got a family history of RA. So maybe that. She has been on Manjaro since about 6 months. Uh, she has lost some weight. She says around 2 or 3 kgs in this thing, because she does some exercise and all that. But any change in depressive status? No. Any change in mood swings? No. So there Monjaro has given her some benefit for which it was primarily designed in terms of weight loss.
Yes.
The problem that I think that is going to happen to us is that if we are using or if others are using for whatever in the patient, the moment patient stops it, things will bounce back. It is like the diet, but it works fast. It works easy. So people who do not have all the other components in place, means they're eating well, their physical activity levels, if for whatever reason it is stopped, the reason for us would be not being able to afford. Primary reason number one. When we give medications, let's say SSRIs, people have a lot of these GI symptoms. So that may not be a real bad thing. Cost is prohibitive. So the moment they complain about cost and they stop, or they kind of, no, I'm not going to take it every week, I'll take once in 15 days, there's going to be trouble. If the other things are not in place, so what is going to happen is if there is going to be 10% muscle loss, 10% weight loss is fine. If I'm 100 kg, I become 90. But in my body composition, there is everything. There is muscle, there is fat, there is bone, correct? Now, if there is 10% muscle mass, and if I'm 45 or 50 years old too, if I stop that and I have no exercise in place, that muscle mass is not going to be regained. And if that muscle mass is not going to be regained, I'll not be able to exercise because there'll be, tiredness and this thing and that thing. So this is some circle which I hope the physicians are telling them. But when we have a difficulty that our patients have got, have put on weight, they are not able to lose it. They have been on this. But if the other things are not in place, we are going to be back to square one with more problems. This is the fact of semaglutide and tirzapatide. Yeah, all of us are not athletes, so we do not have that kind of discipline or training. And even athletes, when they are active athletes and they have that discipline and training, is not a sustainable idea. So unless these two things are in place, the level of physical activity and the kind of diet, if they are not in place, this will work. This will work fantastically, but it will not be maintainable.
Dr. Shubha, any questions?
No questions. I think the last point which Dr. Malay said is the most important thing to take home. Because in our patients, I feel lack of motivation and the negative symptoms and cognitive symptoms are so high that and the major mental illness itself is very disabling. Many of them are unemployed, many of them are single, dependent on their families. So I think they are not ideal candidates for these drugs because we know it will fail eventually.
Yeah, it will fail, but let's say if you are able to add some years to their life, it is okay. And now let's see that if you have got Indian generics, whether they are less costly and whether we are able to give them for a period of time. So we are waiting for that. Tirzapatide is going to take time, but at least of the two mechanisms that tirzapatide has, if semaglutide even with one is available at a reasonable cost, why not? So we look at this way. It's a slight stepwise increment. It is not a drastic leap for people who are, let's say, willing to do everything for weight loss for some reason which is not medical.
Yeah. I think olanzapine did a lot of harm to so many people. Just ballooning them like anything. I mean, iatrogenic.
Yeah. So there are a lot of people who have not gained weight. There are so many patients of mine who have gone some few kilos here and there. They are okay. So maybe they are those slim varieties where we actually need to do a USG and figure out what their visceral fat is doing.
Okay. Thank you for that wonderful session. And thank you, Dr. Karthik, for agreeing to chair this session.
Welcome, man. Thank you, Malay.
Thanks, Karthik. I think
Thank you, sir, for that lucid presentation. Yeah. All explained without requiring any emergency snacks. So A warm thank you to Sir Dr. Malay sir for his insights, to Dr. Karthik Rao for sharing the session with such clarity, and thank you to the Bombay Psychiatric Society for the continuing support to this. Thank you, madam.
My pleasure.
So, and also Alchem CNS for supporting the continuous learning spirit of Brains on Wednesday. So we meet every second and fourth Wednesday, and I'm Dr. Jadeja signing off. Have a calm evening and a metabolically efficient week. Good night, sir.
Right.
Okay.
Good night.
Bye bye.
Thank you.
Good night.
Bye.
Bye.